now going to do a procedure to remove a gallstone, doing a transverse enterotomy, removing the stone and then closing the enterotomy. Now, in one of the previous videos I dealt with a stricture. There was a stricture at this point which the stone, which is still inside, could not get through. So we've demonstrated a strictureplasty. We're now going to demonstrate removing the gallstone through a slightly different technique, doing a transverse incision rather than a longitudinal incision which we made for the strictureplasty. The gallstone impacts at a point which it can't get past. The principle is you then milk the gallstone proximal into healthy bowel. You don't want to remove the gallstone at the point of impaction. So once we're in a piece of healthy bowel, we're going to make an enterotomy to remove the stone and then close the enterotomy. Now there's no stricture at this point, so I'm going to just do a transverse incision and close it in the same direction rather than doing a longitudinal incision which was done for the strictureplasty where I was actually trying to widen the bowel. Here I'm just trying to remove the gallstone. So I'm starting supporting the gallstone. Be careful of your fingers obviously. We make a transverse incision. Just use a bit of tension to widen that enterotomy. Okay, so I think that's big enough. We can then remove the gallstone. I'm now going to close the enterotomy, and because there's no stricture here, I'm closing it in the same direction with interrupted sutures, closing the transverse enterotomy. I'm going to start over at the far end. Again, I'm going to use a 3/0 monofilament. I'm using some non-toothed atraumatic forceps, Mackindos, and a short needle holder. So first of all, I'm going to do a seromuscular bite right at the far end of the enterotomy. Putting that through, and I'm going to tie and put this onto a clip. So flat knots as always. The monofilaments, I'm throwing 7 throws at least. And then put the trailing end onto a clip. And cut. I'm going to do the same at this end. Again, a seromuscular bite. And another seromuscular bite. Trying not to get it tangled. I have to make a confession. This is a Proline. I wouldn't normally use a Proline, but I've got a 2/0 Proline which I thought would show it better on the video. So I'd normally use a PDS. The Proline's much less forgiving in terms of its it maintains its shape. So again, flat knots. Normally use a 3/0 PDS or an equivalent absorbable monofilament. So now I've got a stay suture at either side, and with a little bit of tension. Those just give you a nice enterotomy to close, and now I'll suture towards myself. So we'll start here and move towards myself. We've got 2 targets. Using my fake PDS. Again, I'm just going to do interrupted seromuscular stitches. Nice flat knots. And these you need to have a decent bite of muscle, 2 to 3 millimeters of muscle. Ideally you come out in the middle, so you take one side and then come out and then take the other side, although if it is sitting in front of you, you can take it in one, as long as it doesn't compromise your repair. And just make sure you get nice flat knots. Tension is something you just learn with judgment. It needs to be snug on the bowel wall, not strangulating it, but not too loose. You can use your forceps like that, or if they're non-traumatic, you can use them on the wall of the bowel. I'm regretting using Proline now. It just curls up like a spring. And each suture 2 to 3 millimeters apart, and 2 to 3 millimeter bite of muscle. Oh, I've done something there, I don't know what I've done. That's just caught. There we go. If you see a problem, deal with it. Don't accept something which doesn't look right. If it doesn't look right, it's normally because it's not right. Okay, I think another 2 or 3. Nice big bites of muscle. It's a round-bodied needle, as I mentioned before, so the round-bodied needles split the muscle fibres of the bowel wall. A cutting needle would cut, which can traumatise the bowel more. So the idea is the round-bodied needle slips through and splits the muscle fibres, and then as the needle passes through, the muscle fibres close around the suture material. So I'd always use round-bodied for the bowel or blood vessels for that reason. Okay, so we're now getting towards the end, so I'm probably going to just go through and through here. When you're going through and through, you've got to make sure you're safe and you're not catching the back wall, which again is a judgment thing. In a bowel which is quite proud like this, it's not a problem. Try and leave it long enough to tie without looking like a muppet. Get nice flat knots, 7 throws. I'm going to do one more. I'm going to just use that suture just gently to support myself. Going through and through, nice bites of muscle. And that is it. Cut the stitch. Cut the stays. Cutting stitches about 1/2 centimetre, not too short, otherwise they can't untangle. And we've closed, and because there's no stricture there, we should have a decent way through. When we've finished the rest of the procedures, we'll run the ball from the bottom all the way around and check we can get it through each of the the joins.